The title of my lecture is Considerations for the HIV-positive Woman During Menopause. So what I'm planning to do over the next half hour is to talk a little bit about the epidemiology of HIV in older women and to review with you how we diagnose and manage menopause in women living with HIV, and to try and focus a little bit on what we know and really what we don't know about the unique features of menopause as it relates to women, and then how does this impact their HIV outcomes. So I don't have any conflicts of interest in relationship to this talk, but I do have lived experience. So we've heard umpteen times over the last couple of days that the HIV population is aging, and this is a consequence of two issues. One, we're seeing increasing new diagnosis in older people, but also seeing improved survival of those with HIV infection. And I hope today to put a little bit more of a gender slant on that and to look at the new HIV diagnosis in older people. This is data from Canada. Now I know that lots of people here are from the US, but I think we do have a lot of Canadian representation here. And this is data from our public health surveillance system, particularly for the year of 2016. The blue bars are men, the red bars are women, and looking at new diagnosis by age. And as you can see, although 25% of new infections are occurring in men over 50 years, I wanted to highlight that 20% of new infections in women are occurring in those over 50 years of age. And so when we talk about the 90-90-90, I want to ask the question is, are we addressing that first 90 for older women? So there's not a lot of literature, but when you look back at some of the data that is there, only about 15 to 30% of women aged 55 or older have ever been tested for HIV. And so why not? So first of all, the women are not perceived to be at risk, either in themselves or by their health care providers. Women, even if they do perceive themselves, don't want to be tested, and a lot of that is around concern related to intimate partner violence. Many women go to the physician and sexual activity is not even thought about or discussed. And then the symptoms that they may have are all about aging or menopause or depression and may have nothing to do with HIV. And so much of the literature that looks at the presentation of HIV in women is women often present late, often present with an opportunistic infection, and therefore have higher mortality and less good outcomes. So a question is, if we're seeing now 20% of new infections occurring in women more than 50, is this because of behavioral issues, or is it because of biological issues? And certainly there are some behavioral factors that may influence late onset of infection. And we're in a different world now, and people are ending their relationships early, people are out there dating, and many people in their mid and later life are finding new partners. And women are probably not using condoms because they're not worried about getting pregnant, and therefore they're at risk for HIV disease. There's also lots of issues with power imbalances, particularly in many different parts of the world in terms of women negotiating condom use. And then it may also be complicated by substance use and mental health issues. Well, what about at the biologic level? And there is some thought that with the changes that take place with aging and the menopause, that there can be changes in the cervical and vaginal mucosa that may increase a woman's susceptibility to getting HIV. And despite these theories, the actual data that there is an issue there is actually quite limited. There are some groups that have looked at the R5 trophic lymphocytes in the cervix and found that they may be higher in postmenopausal women as opposed to premenopausal women. But this elevated R5 expression, we're not sure whether that's aging or whether that's menopause or whether it's hormonally mediated. And in fact, there's not a lot of research that truly understands the relationship between those issues. But not only are new infections occurring in women, but also like men, women who have HIV disease are aging. But the epidemic in women, particularly in North America, is a little bit behind that in men because the HIV epidemic did hit MSM in North America before women. This is data from my own clinic, and the blue bars again are men, the green bars are women, and as you can see, the median age in our clinic now is 52 for men and 48 for women, so they're not that far behind in terms of the average age. So we're going to talk today about menopause, and there's a lot of myth, and there's a lot of jokes, and there's a lot of non-certainty, and I look at this for myself, and those of you who know me, I spend a lot of time in the gym, and when I'm there, I have a lake underneath my bike. So is the lake exercise? Is it menopause, or both? So first of all, what is menopause? And it is defined as the absence of menstrual periods for at least 12 months, which correlates with a loss of ovarian function. But menopause doesn't happen overnight. It is a process that occurs gradually, and that perimenopausal transition period is very different for every individual woman. And so part of the problem with the research on menopause is how on earth do you define it? So in general, we define it by history. And for those of you in the audience who've reached it or perhaps have partners that reached it, when did it happen? And if it's defined as a year without, you actually have to think a year back. And so you can well imagine that the self-report is horrible. And most of the cohort studies that have been looking at menopause in women do rely upon self-report. So if we're going to understand this any better, we're needing to have a consistent definition. So in our cohort, it's really something that we're going to need to ask women on each visit so we can actually help with the timing. If you don't have a good history, some people try to use laboratory tests, either endocrine hormone levels such as LH and FSH, or anti-Müllerian hormone levels, which is kind of a research tool and costs a ton of money, but it will tell you something about when ovarian follicle reserve is gone. But again, these things are not reliable, they're not great tests, and are not ideal for timing menopause. So when does menopause normally occur? Well, in the United States, it's been estimated that it's an average of 51 years. So what are the questions that have been raised about menopause as it relates to HIV? So the first question is, does it occur earlier in HIV-infected women? Do they have more symptoms? And how do you figure out if the symptoms are due to menopause or whether they're just those to HIV? How do we best manage it? Does it influence their comorbidity? And I'm going to also raise a question is this a time that we should actually reconsider the woman's antiretroviral therapy? So I'm going to go through these points. So does it occur early? And if so, do we need to worry about this? So what do we mean by early? And again, this is a problem in the literature, is that there's all kinds of different definitions that people use. So early menopause is said to occur younger than 45 years, where premature menopause is said to be less than 40 years. Now this is just arbitrary, and it's been totally based on standard deviations from the norm. Again, you have to make sure that there isn't a pathological process such as surgical chemotherapy or radiation that's induced this, but women in the general population who have early and premature menopause do have associated long-term health risks, which may include premature death, cardiovascular disease, neurological disease, osteoporosis, mood disorders, and psychosexual dysfunction. So what about women? And the literature, again, is all over the map. And the literature will be anywhere from it's the same to 12% of women with HIV have premature menopause, with most reports suggesting that it happens about 2 years earlier. The problem is the confounders, because what are some of the causes of early menopause? Substance use, low birth weight, smoking, ethnicity. And so these are all factors that are going to be disproportionately present in women living with HIV than in the general population. So it's very hard to compare the onset. It doesn't look like premature menopause is impacted by HIV viral load or CD4 count, although could be impacted by a late presenting woman who has lost a lot of weight and is systemically unwell. Why might it occur earlier? Well, there could be an issue with lymphocyte activation or inflammatory mediators that impact ovarian signaling, and it could be if a woman presents late and has an opportunistic infection, this could potentially impact the ovarian pituitary axis. One of my colleagues, Dr. Mona Lufti, is running a very large cohort study across Canada called Chiwas, which is looking at women's sexual and reproductive health. This is a cohort that has involved more than 3,000 women that have been followed over the course of 3 years. And within their study, they recently reported on menopause, the onset of menopause in 232 women. The vast majority of these women were white, about 20% were African Caribbean Black, and 19% Indigenous Canadians, 40% injection drug use, most of them on antiretroviral therapy and suppressed. And again, the median age of menopause in this cohort was 48 years, so if you compare that to the general population, it is a couple of years younger, but again, this was by self-report and has all the limitations that I referred to earlier. But one observation in this study is 29% of the women did report the onset of menopause earlier than 45 years, so are potentially at increased health risks. So why might early menopause occur in these women? So it could be a consequence of immunosuppression, and so it could be related to the low CD4 count nadir. But again, in HIV, it's confounded, and so one of the other reasons for early menopause is smoking, and in smokers, menopause typically occurs a year or two earlier, and it could relate to socioeconomic status, and again, that can be different in women impacted by HIV. So what about the symptoms? We've all heard them. We've all heard them from our mothers, our partners, our wives, other women that we work with, and it varies. And again, different women have different experiences, but it is estimated that most women going through the menopause will have this, and girls, sorry, that they say on average it lasts for 7.5 years. But again, it's impacted by ethnicity, social economic status, but it can have negative impacts on one's quality of life, performance at work. But again, if people have tried to look at this in women living with HIV, and again, the literature is mixed with no consistent association, but most studies suggest that women who are living with HIV have increased in menopausal symptoms by about 25 to 65% relative to the general population. But again, the confounder is the impact of socioeconomic status, depression, and other life events. So what about some data? This is Lorraine Kerr, who is a psychologist in the UK who's done a lot of work in this area. She looked at 140 women more than 45 years of age and found that the older women had higher anxiety scores and more severe depression compared to their younger counterparts using one of these menopause-specific quality of life questionnaires. And what was disturbing in her work is, although a very large number of these women did report distressing symptoms, the vast majority of them did not seek help for their symptoms. The other group that's done a lot of work is Shima Tariq and her group, again in the UK. They have now formed something called the PRIME study, which is the positive transition through the menopause. So it's an observational study of women between the ages of 45 and 65 across England. And they have included 710 now women included in their cohort. These are some data that they presented at the International Women's Workshop Conference last year, and found that those women who either have somatic complaints or urogenital symptoms associated with their menopause are much more likely to suffer from psychological distress, anxiety, and depression. So these are very important questions that we need to address with our women in our clinics as they are aging. The same group also compared the subjects in the PRIME study to a national survey of older women on their sexual attitudes and lifestyles. And as you can see in the table 2 on the left of this graph, the women living with HIV had a much higher incidence of poor sexual function and dissatisfaction with their sexual function than the general population. And I would challenge the clinicians in the room as to how often you discuss these issues with their women in your clinic and what impact that that's having on their lives. So does menopause negatively impact HIV disease? Well, the literature that I've looked at have suggested no, that there doesn't seem to be any impact on either T count, viral load, or response to CART as women transit through the menopause. But is there something going on? And we've heard a lot of this conference over the last few days about the increased incidence of inflammaging and evidence of elevated markers of T-cell activation and soluble markers of immune activation in aging. And this was data that compared HIV-positive women to HIV-negative women going through the menopause. And as you can see from the p-values, and I think all of the markers are not necessarily important, but there are a large number of these inflammatory markers which are even higher in elderly HIV-positive women compared to HIV-negative women at the same age. And the question is what is the impact of these inflammatory markers, and may they be responsible for more comorbidity in women as they age with HIV? And we've all been familiar with Giovanni's initial work looking at the counting of comorbidity in HIV-positive individuals compared to HIV-negative individuals. Claire Candela is an investigator in Canada who did the similar thing, looking at comorbidity in HIV-infected women in Ontario compared to age-matched controls, looking at the burden of comorbidities. So the blue bars are women living with HIV, the red bars are those of the Canadian or Ontario population. And again, you can see that the number of comorbidities in any age decade is higher for the HIV-infected women than their HIV-negative counterpart, and those curves are splitting even more when we get to women more than 65 years of age. So why? And is it this problem of losing their ovarian reserve? So this is a risk factor for increasing comorbidity in the general population, and if we add that to HIV, are we seeing an even greater effect? So this was a small paper in AIDS a couple of years ago who was looking at HIV-positive and negative women and looking at those who had undetectable anti-Mullerian hormone and therefore postmenopausal. And of those who were HIV positive who had an undetectable anti-Mullerian hormone level, they had a much higher incidence of coronary atherosclerotic plaque and non-calcified plaque, suggesting that they may be at higher risk of having coronary artery disease. And this was also associated with some of these inflammatory markers of inflammation, suggesting that they may be at higher cardiovascular risk. Well, does that translate into disease? And we think about HIV and we think about the increased risk of coronary artery disease, but it's usually studies in men. And does this hold true for women as well? So the only data that we have is coming from the VAX, the veteran aging cohort, and in that cohort there are 2,000 women, of which a third are HIV infected. And as you can see from this Kaplan-Meier curve, the HIV infected women had a 2.8 increased hazard ratio of coronary artery disease compared to their HIV negative controls. So it would appear that the increased risk of heart disease as we age with HIV is even more important in women than it is in men. So what about stroke? And this was a study that was just published in AIDS a couple of months ago, looking at the partners HIV cohort and the incidence of ischemic stroke in women with HIV in the gray boxes compared to the HIV-negative women in the dark boxes. And again, you can see the risk of ischemic stroke being higher in the HIV-infected individuals, particularly in those more than 65 years of age. And she also did a similar study looking at the difference in ischemic stroke between men and women living with HIV. And as you can see, at the younger ages, the incidence of ischemic stroke was higher for women than it was for men. The other comorbidity that we worry about as women age is osteoporosis. And again, what is the additive effect of HIV? Because we know that HIV and some of the drugs that we use to treat it are associated with higher incidence of low bone mineral density. Again, the complicating factor is the other risk factors of injection drug use, cocaine, and race. But we have seen now a lot of strategies looking at means of changing antiretroviral drugs, such as getting off of tenofovir and switching it to the prodrug tenofovir alafenamide, or going on to NRTI-sparing strategies to show less bone mineral density loss. Now, the interesting thing is most of this work is being done looking at low bone mineral density, but in the general population, changes in bone mineral density have only been correlated with fracture risk for women who are postmenopausal. And of course, most of the studies that we do in HIV are looking at young gay men, so we do not have the data that we require for the impact of these drugs on osteoporosis in aging women. But they do seem to be at higher fracture risk. So again, data from the WIS study looking at HIV-positive women in blue, HIV-positive women in red compared to HIV-negative women in blue, showing that there is a higher fracture rate in women living with HIV. But when you put in the multivariate model, age, race, drug use are confounders of this association. So the comorbidity things that we need to think about as women age with HIV, that in cardiovascular disease, we have an increased risk with HIV. We also have an increased risk with premature menopause. Women with HIV may have an increased risk of premature menopause, but unfortunately, we don't have that data yet on whether this translates into higher cardiovascular outcomes. The second issue is one of bone mineral density and osteoporosis. Again, increases with age, increases with HIV, increases with antiretroviral drugs, but the studies have not included very many women in those studies. Again, Giovanni and I are currently doing a study in perimenopausal women looking at that switch from tenofovir to tenofovir alafenamide to see if we can actually see some clinically relevant outcomes. The other issue as women go through the menopause is this is a period of depression. Again, a study from the WIS comparing positive women to control women showed that there was no incident difference in the prevalence of depression between the two groups during menopause, but the odds ratios for both groups were higher in the premenopausal period, and this is something that we need to think about. So the other question is as women transit through the menopause, should we be rethinking their antiretroviral drugs, changing those to decrease the risk of comorbidity, or do we even need to think about drug doses and drug levels as people go through the menopause? And the data here is very, very thin. The only studies I could find is this one that Chris Patterson presented at CROI in 2011, looking at tenofovir levels in women on that drug before they reach menopause and after they reach menopause. And as you could see, the drug levels of tenofovir did increase both in the blood and in the cervical vaginal secretion. But what we don't know, did this happen because of aging? Did this happen because of menopause? Or did this happen because of declining renal function or the combination thereof? The WIS also looked at tenofovir in 105 women and found that those individuals with the highest tenofovir area under the curve had lower GFRs compared to those in the lowest tertile. And as time went on, that difference widened. So there does seem to be increasing tenofovir doses as women age. The reasons for it are not clear, but if tenofovir is going to impact bone, this could be a very vulnerable period for women as they transit through the menopause. And the only other drug that was studied is Reltegravir. This is a study that was done by Angela Kashuba's group looking at Reltegravir levels in HIV-negative and pre- and postmenopausal women, and I think you can see that there's a large flux in doses that really are not different in that population. So lastly of all, what do we do about managing menopause in women living with HIV? Well, we do all the motherhood things, right? Make healthy choices with diet and exercise, stop smoking, take your drugs, and manage your symptoms. But if these don't work, what do we do about hormonal replacement therapy? Well, in the general population, there are huge controversies around this. There have been meta-analyses done, and there's a lot of uncertainty, but there does seem to be a slight increased risk of stroke, of DVT, coronary artery disease, and breast cancer. There doesn't seem to be a risk of endometrial cancer, and there's a decreased risk of colon cancer and hip fractures. So there's some balances that we need to take. Clearly, these therapies do improve vasomotor symptoms. The problems with hormone replacement therapy is compliance tends to be poor. They are associated with adverse events such as breast tenderness, weight gain, and depression. They cost money. And the biggest problem with the studies, it's all about the timing. So the studies that have shown increased risk of stroke have suggested that they've been introduced in the late menopausal period as opposed to the early menopausal period. There's controversy as to what active ingredients should be, how they should be delivered, and for how long. So much uncertainty in the general population, but a balance of risk. A little bit higher risk of stroke and DVT, a little bit less for colon cancer and hip fracture. So in HIV, nothing, no literature at all, but theoretically problems because boosted protease inhibitors, cobicistat and NNRTI, because of their metabolism through cytochrome P450, are going to impact upon the dose of these agents, and so you have to titrate them to effect. If you look at the literature, less than 10% of perimenopausal women are on these hormonal therapies. Why? Well, we're worried about increasing their pill burden, impacting their adherence to their antiretroviral drugs. I've already mentioned that women with HIV are at higher risk of coronary artery disease. We add to that a higher rate of smoking. We add to that a higher rate of dyslipidemia from their antiretroviral therapy, so that raises concern. Are women with HIV at higher risk for breast cancer? The general cancer surveys suggest no, but we really haven't followed women long enough to be certain that the immune surveillance associated with HIV may not predispose them to higher rates. And we all know that HIV has a 2 to 10-fold higher risk of venous thromboembolism, which again could be additive onto the estrogen therapy, although transdermal estrogen may confer less risk. So lots of reasons to be concerned about using these therapies in women living with HIV, but some women clearly need them in order to deal with their multiplicity of symptoms. And if it's necessary, you should try it as soon as possible when they reach the menopause at the lowest possible dose and for as short as possible. So I'm going to close it up there. I've outlined with you that not only in men, but the prevalence of HIV infection in women is increased. The differences in the age of onset, rate of menopausal symptoms, and link to comorbidity relative to the general population remains debated. That this perimenopausal period is a time that we should reconsider their antiretroviral therapy and the potential for adding to comorbidity. That hormonal replacement therapy may control their vasomotor symptoms and decrease their fracture risk, but we have to be concerned about some other balances, and you need to think about the drug interactions with their antiretroviral therapy. I thank you.